So welcome again. We are here as members of the ABC Science Collaborative to discuss COVID-19 with a focus on vaccines for prevention. We have with us today Dr. Michael Smith, who is a professor of pediatrics at Duke University, and Dr. David Weber, who is a Sanders Distinguished Professor of Medicine, Pediatrics, and Epidemiology at University of North Carolina at Chapel Hill. I'll hand off to both of you to take us away.
Thank you. The format is, thank you for joining us this evening. We'll take questions in the comments section in YouTube, and we'll supplement our presentations with some of your questions. Questions that are not answered during the webinar will be collected and may be combined with other questions will be addressed in a frequently asked questions document or future webinars. The webinar slides and videos are available for your viewing and use at our website, abcsciencecollaborative.org. Thank you. Just the disclosures, Dr. Smith is a site investigator for the adult and pediatric Pfizer COVID vaccine trials being conducted at Duke University. Duke has received funds from Pfizer to support this trial. Dr. Weber is the consultant for Pfizer, Merck, PDI, Germatech, and Dynavax. And with this, this is Dr. David Weber from UNC. I'm going to start off, and then I'll hand it to my colleague, Dr. Smith. So coronavirus, this is a tracker that is available from the New York Times. What I want to point out is a very, very large number of studies are underway to develop COVID vaccines. Most are in the early phases, phase 1 or 2. Phase 3 are the definitive trials, randomized clinical trials. 6 have been authorized and approved, and 4, because of problems in the development, have been abandoned. But it's likely we have 3 vaccines released under an FDA emergency use authorization. We will see new vaccines released in the next several months. Next slide. Now, these vaccines can be made through a whole variety of different technologies, which are listed here. Inactivated vaccines are sort of the classic polio vaccine. Live attenuated vaccines are like mumps, measles, rubella. The others are newer technologies. Down at the 7 o'clock position are mRNA vaccines. These are new technologies. This is the Moderna and Pfizer vaccines. And then virus vectored vaccines are at the bottom at the 6 o'clock. This is what the most recently released vaccine, Johnson & Johnson, uses. However, this is not a new technology. There are virus vectored vaccines available for Ebola. Next slide. So let me first tell you about how the mRNA vaccines, again, that's Pfizer and Moderna. In the upper left is your coronavirus. You can see the little spikes coming out. This is essential for replication of the virus. Coronavirus, corona meaning crown, because of the spikes, that's how the virus got its name. Inside is the genetic material. We cut a piece of that genetic material out, that is the mRNA for the gene that makes spikes, and we encase it in lipids. We're only taking part of the RNA out, so these particles are not infectious. You cannot get COVID from any of the currently released COVID vaccines. And then they inject this into your arm, the lipid dissolves, the mRNA is released into the human cells. It makes the human cells convert that mRNA into spike proteins, which appear on the surface of the cell. The bodies recognize these as foreign and develop antibodies, and then you develop immunity. Next slide. So this is very similar. At the bottom left is our coronavirus. Again, we take the mRNA out, we convert it into DNA, and then instead of putting it in lipids, we put it into an adenovirus. These are viruses which cause respiratory and other infections, but these viruses are engineered to be non-replicative. They then penetrate human cells, release the DNA, which is converted to mRNA, and again, you make spike protein, which appears on the surface of the cells. And again, the body recognizes these as foreign. You develop antibodies and develop immunity. Next slide. So let's talk about these vaccines side by side. Here we have the Pfizer vaccine, again, mRNA. All the vaccines develop a spike protein, 2 injections, 28 days apart. This one is released for greater than 16 years of age. All the other vaccines we have are released for 18 and above, and it's 95% effective against symptomatic COVID. It does require stringent storage temperatures and it's injected IM. The Moderna vaccine is virtually identical, except it's 2 injections, now 28 days apart. and released only for 18 above. Again, 98% effective for COVID-19. We'll talk more about side effects later in this presentation. The Johnson & Johnson vaccine, again, uses spike protein, but an adenovirus vector. Importantly, it does have some advantages over the Pfizer Moderna vaccines. One, it's single dose, and two, the adverse events are somewhat less. And finally, it's more stable at refrigerated temperatures. I want you to notice among these three vaccines that more than 100,000 people were in these trials. So we have excellent data on the effectiveness of these vaccines. Now, the Johnson & Johnson vaccine is about 75% effective for moderate to severe disease, 85% effective for more severe disease. But I want to point out to you, all three vaccines are 100% effective for preventing hospitalizations and deaths. Next slide. Now, I want to point out one of the concerns, of course, with vaccine development is disadvantaged and marginalized populations have not been well, their numbers in these trials have often been much lower than their population basis. But I want to point out in these trials, about 10% of the trial participants were African American, slightly less than their percentage in the US population, but Hispanics and Latinx were overrepresented, in part because some of the trial sites were outside of the US. So again, 100,000 people, large numbers of marginalized populations were part of these trials. And I will point out to you that the effectiveness of these vaccines was not different depending on age, gender, race, or ethnicity. Next slide. So what about the vaccine effectiveness in real life? This is data from Israel. As you know, this is one of the 2 or 3 countries with the 2 or 3 most used vaccines. They've now immunized more than 80% of their population. This was vaccine effectiveness of day 14 through 20. This is with a 2-dose vaccine. So this is really only with 1 dose, about 50% effective with only a single dose, 57% effective for symptomatic disease, and 72% effective for preventing death. Now, 7 days after the second dose, 92% effective for any infection, 94% for symptomatic disease, and 100% for preventing death. This is why we believe that with the 2-dose vaccine, you really need to get the second dose. It gives you tremendously improved immune response and additional protection. Again, the vaccines worked across all age groups. They were slightly less effective in people with multiple underlying diseases, but even in that group, they were very effective. Next slide. Now I'll turn it over to Dr. Smith, who's going to talk about vaccine safety and some other issues. Thank you very much.
Thank you, Dr. Weber. Good evening, everybody. So Dr. Weber shared us some information about the efficacy of these vaccines in clinical trials and the effectiveness in real life. Basically, how well do they work? But I think an equally important question that you may be asking yourself is, are these vaccines safe? So the first thing to point out is that safety is a critical part of the pre-licensure vaccine trials that Dr. Weber mentioned. And in the clinical trials, remember, you have people who receive the actual vaccine and people who receive placebo. So what you're able to do is look at rates of adverse events in people who got the vaccine as compared to those who got the placebo. And really the side effect profile in the trials for both the Pfizer and the Moderna mRNA vaccines are very similar. You have mild to moderate side effects were common. And when I talk about mild to moderate side effects, it's mostly what we call local or systemic reactogenicity. So probably not surprising to most people that if you get an injection in your arm is likely going to be sore for the next day. It might be a little bit swollen and it might be a little bit red. That's kind of what we're talking about. And the data do show that for the second dose of the mRNA vaccines, again, that's 21 days later for Pfizer, 28 days later for Moderna, it can be a little bit more severe and more common. Just to give some context, about half of all people had some sort of reaction after dose 1, and closer to 2/3 had some sort of reaction after dose 2. But again, these are mild to moderate side effects. In contrast, the Johnson & Johnson vaccine studies found that moderate to severe side effects were very uncommon. And as you heard in the disclosure section, I've been an investigator for the Pfizer trials here. You could guess when people came back for their study visits which patients, which study subjects received placebo as compared to vaccine, because it tended to have those side effects I mentioned. It hurts a little bit more. Talking to colleagues across the country who were involved with the Johnson & Johnson trial, they said it was much more difficult to figure out who received placebo and who received vaccine because the side effects were so mild. Next slide. So that's from the trials. However, it's also important to point out that we have several post-licensure vaccine safety mechanisms in place in the United States. And that's important. Dr. Weber said there's more than 100,000 people who have received these vaccines, but once a vaccine is approved for use, it's still important to follow the population for vaccine safety. And that's important because there may be some side effects that are so rare that they occur in 1 in every 100,000 individuals or more. So, a trial with only 75 or 100,000 people might not pick up such a side effect. Additionally, it's important to keep following vaccine safety because side effects may occur in individuals who were excluded from the trials. For instance, the following groups were excluded from the initial clinical trials. People with a known previous COVID infection, that was a reason not to be in the trial. Although I will say less than 5% of individuals did have COVID and didn't know it based on their serologic testings. And pregnant women were excluded from the original vaccine trials. There are trials with pregnant women that are ongoing now, and women who did get pregnant during the course of these trials had no adverse events. Next slide. So there are several long-standing post-licensure mechanisms to assess vaccine safety in the United States. The first is VAERS, or the Vaccine Adverse Event Reporting System. The second is called VSD, or the Vaccine Safety Data Link. And the third is Clinical Immunization Safety Assessment Program, or CISA. New for the COVID-19 vaccine platform was this app called vSafe that many of you may have heard of. This is basically an after-vaccination health checker app. You're allowed to, encouraged to enter any symptoms you have after vaccine. And this gets fed back to the CDC for vaccine safety purposes. And you can also get a reminder when your next vaccine is due. But I want to talk about VAERS, VSD, and CISA very briefly. Next slide. So VAERS is a passive surveillance system that allows anyone, including a healthcare provider, a patient, or their family, to report any expected sign or symptom after vaccine receipt. So VAERS functions as an early warning system. Basically, if something bad happens to you after the vaccine, please do go ahead and file a VAERS report or have your doctor file a VAERS report. Now, importantly, there's no comparison group. It's only patients who received a vaccine and had an adverse event. So VAERS are what we call hypothesis generating, meaning they can be used to generate ideas to explore a potential vaccine adverse effect or side effect, but you really need a more rigorous study to explore causation. So VAERS data do not imply causation in and of themselves, basically just a way to collect things that happen to a group of people after they got the vaccine, and then you do further studies to see if there's a potential causal association. Next slide. And probably the most robust way to do that is through the Vaccine Safety Data Link, or VSD. And the VSD is a partnership between the CDC and several geographically diverse managed care organizations or insurance companies across the country. The VSD data set includes clinical data for just over 10 million people each year. And during COVID-19, these data are updated weekly. And basically they create two categories of people who received a COVID vaccine and people who did not receive a COVID vaccine. And what this does is allow to look at rates of any adverse event of interest. So for instance, a heart attack. How many people had a heart attack after getting the vaccine as compared to how many people had a heart attack without ever having a vaccine? And this is important because as you can imagine, when you vaccinate a whole lot of people, and as of today, more than 81 million Americans have been vaccinated with at least one dose, about 25% of the population. Things are going to happen to those people. And it's really important to have a system in place to understand whether the vaccine was related or not. COVID vaccines are good at preventing COVID, but they're not able to prevent other things like heart attacks. Next slide. Here is an example table. This is a publicly presented table by the CDC earlier this year. And again, just gets at the point that I mentioned. You're able to compare in the fourth column over, the number of events in vaccinated individuals. And then one column over on the right, events in unvaccinated. And then that final column on the right is there a signal? So a signal would be if cases are more common in people who are vaccinated as compared to those who are unvaccinated. And looking at the list of diagnoses, you see acute disseminated encephalomyelitis was number one, and the CDC and FDA put this list together well before the COVID vaccines came out, and you can see no one in either group had that. However, for acute myocardial infarction or heart attack, there's one event in the unvaccinated group as compared to 179 events in the unvaccinated group. Sorry, make sure I said that right. One in the vaccinated group and 179 in the unvaccinated group. And therefore, there's no signal because more people who are unvaccinated had heart attacks than people who were vaccinated. And again, as more and more people get vaccinated, we'll be able to make a better estimation of these. But it's important that you all know that vaccine safety is taken very seriously once a vaccine gets approved for routine use. Next slide. The last vaccine safety mechanism I wanted to tell you all about is called CISA, or the Clinical Immunization Safety Assessment. And CISA is a long-standing partnership. It's now more than 15 years old, between CDC and 7 medical research centers across the country that provides expert consultation and conducts clinical research on vaccine-associated health risks. So the CDC created a dedicated COVID program called CISA COVID Vax that launched in December 2020 when the EUAs came out. I am fortunate enough to be part of this team at Duke University, and we've had daily check-ins 7 days a week to discuss emergent vaccine safety concerns from across the United States. So we have faculty in infectious diseases, obstetrics, geriatrics, cardiology, neurology, and allergy, who are all part of the Duke CISA COVID Vax team. And we're also doing studies. So I mentioned that pregnant women were not included in some of the original phase 3 clinical trials. We are part of a cohort study following a group of pregnant women who get COVID vaccine over time to see how they do and see how their babies do. And also I'm leading another study looking at children who get vaccinated. Next slide. So when you put this all together, I'm very confident saying that these vaccines are safe. And I want to make sure everyone understands that that's not a one-time thing. We're literally every day, there are more and more data to help us understand how safe the vaccines are. So when it comes to decisions that you may be making about vaccine, common question is, should I get a vaccine? And in general, if you have the ability to receive a vaccine, you should. There are really only a few exceptions to that. First, if you're currently sick with COVID, we ask that you wait until you're no longer in isolation. Now, nothing bad will happen to you if you get the vaccine while you have COVID, but the last thing you want to do is bring COVID into a big group of people waiting around to be vaccinated, which could be a public health disaster. Similarly, if you're currently quarantined, we ask that you wait until your quarantine has ended. If you received monoclonal antibodies against COVID within the past 3 months, we ask that you wait 90 days until your monoclonal antibody treatment. And finally, if you just received another vaccine and then you have the opportunity to get your COVID vaccine, the CDC recommends that you wait 14 days from that most recent vaccine. Next slide. So what about some specific populations? These are some common questions that we've received so far. What about women who are pregnant or breastfeeding? And as I mentioned, they were not included in the original studies. However, pregnant women and breastfeeding women are included in other studies moving forward. Important to note that there is no scientific reason to expect harm to mom or fetus. The women who did become pregnant during the clinical trials, no harm has come to them or their babies. And then expert opinion does support getting these vaccines. So the American College of Obstetrics and Gynecology and the Society for Maternal and Fetal Medicine both state that vaccines should not be withheld from pregnant women. And vaccines should be offered to lactating women similar to non-lactating women. As I mentioned, there are trials ongoing, and pregnant women are allowed to get the vaccine per the ACIP regulations, and there have been no ill effects noted in pregnant women to date. Finally, vaccines during pregnancy also protect infants. We've known this for some time for other diseases such as influenza and pertussis, and now it's been shown that pregnant women who get COVID vaccine also pass on that protection to their babies. Another big group is immunocompromised individuals, and as Dr. Weber mentioned earlier, you cannot get COVID from COVID vaccines, and therefore it is highly recommended that immunocompromised individuals receive vaccine because they're at higher risk. People who have had COVID, we've already touched upon. If you've had COVID, you should still get vaccinated. And finally, children. As Dr. Weber mentioned, 16 and 17-year-olds are eligible for the Pfizer vaccine. We did the Pfizer vaccine study here at Duke. The 12 to 15-year-old study is now completed. Pfizer is reviewing those data and will shortly be submitting to the FDA. The 6-month to 11-year-old study started this week. Moderna has 2 studies in children underway, 1 study in 12 to 18-year-olds, and another study that started last week looking at 6-month to 11-year-old children. Johnson & Johnson, I don't have any inside information for this one, but according to their website, they have several studies planned in children and teenagers. Next slide. Another common question is, which vaccine should I get? And in general, you should get whichever one's available. As Dr. Weber said, they're all excellent at protecting severe disease and death. Again, here too, there are a couple of exceptions. So the Johnson & Johnson vaccine is recommended if you had a severe allergic reaction or anaphylaxis after dose 1 of an mRNA vaccine, or if you have a known allergy to polyethylene glycol, which is a component of the both mRNA vaccines. And I will say, I'm not sure if I have an allergy to polyethylene glycol, and you may never have heard of that yourself. If you've had a significant allergic reaction to a medicine in your life, just check with your doctor to see if polyethylene glycol or PEG is an ingredient in the medicine that causes your allergies. In contrast, Moderna or Pfizer is indicated if you have a known allergy to polysorbate. And again, I'm not sure which of my medications have polysorbate. So if you've had a severe drug reaction, check with your doctor or pharmacist. Next slide. As we close here, we talked about the vaccine being effective at preventing disease. We've talked about the vaccine being safe. And now recently the CDC has made recommendations for what fully vaccinated people can do in terms of getting back into some of our pre-COVID normal activities. So fully vaccinating people can do the following activities. And again, these do not apply to healthcare facilities, workplaces, or schools. But you can visit with other fully vaccinated people indoors without wearing masks or physical distancing. You can visit with unvaccinated people from a single household who are at low risk for severe COVID disease indoors without wearing masks or physical distancing. So grandparents, you can go visit your grandkids or have your grandkids visit you. You can refrain from quarantine and testing following a known exposure if asymptomatic. And I think, you know, we're here as part of the ABC Science Collaborative, talking about getting teachers and students back into school safely. This is huge because we've seen, as you all know, that quarantine is actually a bigger issue when it comes to keeping schools open than actual transmission of COVID within the school setting. So the fact that fully vaccinated people do not need to quarantine is really a huge plus and a huge reason to be vaccinated. Now, that said, fully vaccinated people should continue to take precautions in public, like wearing a well-fitted mask and physical distancing, and avoid medium and large-sized in-person gatherings. And just to be clear, remember when we talked about fully immunized, that means 2 weeks after the second dose of the mRNA vaccines, or 2 weeks after the single dose of the Johnson & Johnson vaccine. Next slide. So that ends the didactic portion of the evening. And we look forward to answering any questions that you all have. Thank you.
Thank you so much, Drs. Weber and Dr. Smith. We have a few questions already coming in, and some of them allude to points you made already, and I may just ask for a slight clarification to help our viewers understand the point that was being made. So Dr. Weber, handing off to you first. Someone has a question specifically about what it means to be vaccinated. And I say that in the context of how we interpret the risk for infection. So if you are fully vaccinated, and we know that can be different depending on the type of vaccine you get, does it mean you will not get COVID-19?
The way the studies are done, they look at the number of people or rate of the people and who did not get vaccine versus who did get vaccine. So when I talk about a vaccine being 95% effective, it means for every 19 people who were unvaccinated, one person who was vaccinated did develop disease. That is, they became symptomatic, which is what was the endpoint of these trials. So the vaccines are not perfect. They're very, very good for keeping you from developing illness, and they're even better at keeping you from becoming hospitalized or dying. In these cases, the vaccines were virtually 100% effective for that more severe outcome. What we don't know for sure is whether you can become infected and be infectious without developing any symptoms. That is, the vaccines rev up your immune system so you never become ill, but maybe the virus could grow in your nose or your mouth or your throat and therefore infect others. There is some evidence that the vaccines prevent this somewhere between 75 and 90% of the time, but that's still preliminary evidence, which is why outside of the changes for small groups of people meeting other small groups of people, generally fully vaccinated, it is still recommended, even if you've had vaccine, you continue to wear a mask when in public and in large crowds, particularly indoors, and to the extent possible, physically distance. Thank you.
Thank you for that. There's a follow-up question that just came in, and this may allude to local practices, which, as you know, we have a national audience, and that may be somewhat different across each state. But if you're fully vaccinated, do you still need to participate in daily screening? Say, for example, at a school, that may include things like temperature checks. What do you think about that?
So the CDC is, with the exceptions that Dr. Smith mentioned about being in small groups, has not changed explicitly any of its guidance for either medical facilities or for workplaces. So at the present time, for both hospitals, any healthcare facility, and workplaces, they are recommending that people be screened for symptoms of COVID, and if they're present, that they call either their occupational health provider or their local medical provider, and with them decide whether they needed to be tested for COVID, and that they continue to wear masks and physical distance. Particularly important when your workplace, if you are taking your mask off to eat and drink, that you stay 6 feet apart from other individuals. So CDC has not changed any of those recommendations at the present. I should say they did change one recommendation, which is useful, which is that if you have a transient exposure, like at the workplace, you get called up, you were eating near somebody and they turned out to have COVID, they would say that you don't need to, in that case, be tested for COVID within 90, so you have to be fully immunized, and then up to 90 days. So in that period of time, short window, you would not need to be tested. Now, if it's an ongoing exposure, like somebody you're living with, that would be a different circumstance.
Yeah, absolutely. And I think a lot of people are expecting that 90-day limit may disappear soon, but it's still within the guidance. So switching gears a little bit, Dr. Smith, we have quite a few questions about side effects. And we have a multi-layered question. I'll identify sort of the high-level point here. We talk about people having side effects, particularly after the second dose. But what about those that have nothing? So if nothing happens, if you have no side effect with either dose, does it mean you still produced the appropriate antibodies you were meant to produce? And then the follow-up question to that is, have you seen the differences in those that respond to side effects across age, race, ethnicities? Are there other reasons to explain some of the reports of side effects?
Great, thank you. So there are two questions in there. And I think the first one was, if you don't have a side effect, did the vaccine work? And I think, for most vaccines, yes, that is true, because part of the licensure process is not just, did you have a reaction, but was it, A, did it reduce your disease, and B, did you develop immunity? So, before these vaccines received their emergency use authorization, you had to prove that they were able to induce immunity. So those two, immunity and safety, are kind of two separate outcomes that are not really linked. That's the first thing. And remember, I said, 50% of people have a reaction after dose 1. About 2/3 of people have a reaction after dose 2. So that means half the people don't have a reaction to dose 1, and a third don't have a reaction to dose 2. So I wouldn't be too worried about not having a reaction. And then the other thing, I think the question was, is there any differences between groups of people that had and did not have a reaction? And quite honestly, the one that was studied really was age. So remember that that the Pfizer vaccine goes down to 16. In the large phase 3 clinical trial that they presented, they divided into 16 to 55, and then 55 to 85. If you were in the younger group, you were more likely to have systemic and local reactogenicity. And I think based on kind of how the people I work with reacted, the younger you are, our medical students, our residents, our fellows, we're much more likely to have a severe reaction. I shouldn't say severe, not severe in the FDA sense, but something that made you feel lousy for a day and perhaps kept you out of work than some of the older folks. So age really seems to be the big driver. To date, there's not been any major differences in terms of racial or ethnic background in side effects.
Thank you. So switching gears again, I think we may go back and forth on this because I think some questions come up about side effects and some questions are coming up about how the vaccine works. The CDC recently released some guidance about what you can do now that you are vaccinated. For school settings, not much may have changed. As we all know, we're still promoting all of the mitigation practices that we know work, including masking, distancing when able, and all of the cleaning that we've talked about. There's a question about quantifying the risk of transmission between vaccinated and unvaccinated individuals. And just as maybe focusing on what we should be doing going forward, Dr. Weber, can you address that question about what the research has shown about transmission?
The answer is yes. So obviously, if you don't become infected, you can't transmit. So we know certainly that about 40% of people, if they become ill, are asymptomatic, 60% are symptomatic. So the vaccine clearly is going to reduce the risk that you would become ill and transmit disease. As I've said, though, we don't know it's going to reduce it to zero. One, some people can still become infected, but the vaccine will prevent you from becoming ill. And even if you don't have any symptoms, there may be a chance you could get infected and pass it on to others. So the answer is yes, vaccines tremendously lower the risk of you acquiring disease and passing it on. But because it's not zero at the present time, having a vaccine doesn't change anything in terms of wearing a mask or physical distancing when outside of your home bubble. Now, again, as we get more information, that may change in the near future, but at the present time, that is the current CDC guideline based on the best available data at the present.
Following up on that, we know that based on the categories, mostly adults will get vaccinated before children can get vaccinated. We've had different schedules for returning to school in person. There's a question about safety for return to school if we see sort of different populations being vaccinated. Actually, both of you could weigh in on that, just about the prior history of safe settings within the school when certain mitigation practices are followed, but also we don't expect children to be fully vaccinated by the summer. So how can people think through the different vaccination groups and what they should do in the school setting?
Yeah, I can take a first stab at that one. So yeah, I think as you point out, you know, our group, the ABC Science Collaborative, has shown that really children can return to the school safely by just following the 3 W's. So wearing the mask, social distancing, and hand washing. And I know Dr. Weber probably knows this very well. In all of our slide sets, we use that Swiss cheese model. Anyone who's seen my talk knows that I really like to talk about that. And then it's not just the effectiveness of a single mitigation strategy, but it's multiple put together. So the way I think about this is we know that children can be back in school safely, both for themselves and teachers, if you follow the 3 W's. If you layer vaccination of the teachers on top of that, it gets even safer and the likelihood of disease transmission goes down even further.
Yeah, I'll mention a few comments. So the lack of immunizing children is not because we won't have enough vaccine. We expect to have enough vaccine by the end of May to immunize all adults in the United States. It's simply that the trials demonstrating safety in children and the vaccines may need to be reformulated in the terms of the amount of the antigen they present for children will not have been conducted by that time. So we do expect that we will have data first for 12 to 16-year-olds, and then later for 6 months to 11-year-olds, coming out somewhat later. And certainly by the end of this year, we will have both vaccine and data about safety in children. That said, obviously, one of the big risks for children, of course, tends to be adults, because adults tend to have more contacts than children do, going to large gatherings, for instance, in sports arenas and others. So by immunizing all the adults in a school, meaning the staff, teachers, and visitors, that will decrease the risk of children. And our data showed that child-to-child transmission is uncommon with the mitigation strategies we're already using. Those will have to stay in place until we can fully immunize children. But certainly immunizing those in the school system, all the staff, will both protect them, but it will also provide a layer of protection in addition for children.
Thank you. This question is again for both of you. So we know, as we see changes in practices in the community, and some of it is related to CDC guidance. So these are people that are following guidance. We know that mask wearing may change. We have a great question from a viewer that's asking about just increased concern about people letting up on all of the mitigation practices you mentioned. So the Swiss cheese model, we know it's a bundle of things that should help. So what message can we put out there? What message do we have for unvaccinated students, potentially really everybody in the school setting as they return to the classrooms? The caveat here, though, which I think is interesting, we haven't addressed this as much, is given new variants and potentially increased spread. Would you say anything different? How would you address that question?
Let me start with that. First, if I have any two take-home messages for the audience, one is in terms of which is the best vaccine for you, the best vaccine is the one you can get first. The second take-home message is the most effective way of preventing others from becoming ill is for everybody to wear a mask. An infected person who may have no symptoms, if they have a mask on, they don't spew out infectious particles. If you're uninfected, you don't inhale them. And I will tell you, and this is true at Duke as well, at UNC, we've taken care of more than 1,700 people with COVID. Not one of our healthcare workers taking care of those patients has ever developed COVID. And the answer is why? Because they're properly wearing their masks. So masks are just tremendously effective in preventing disease. And unfortunately, we're going to need to continue to wear masks, particularly in schools, until we have community levels of protection and we drive the rates way down. So likely for a number of months to come, we will need to continue wearing masks, but that is the primary means of protection, wearing a proper mask. When I talk about double masking, by the way, I mean the infected person wearing a mask and the non-infected person wearing a mask. It is true, you can improve the fit of the mask by just simply tying the cords where they come out of the mask or pulling them tighter behind your head just with a simple hair clip. All of those things work, or both in our laboratory here at UNC or by CDC, putting on a medical mask or a multi-ply homemade mask, and then putting something that's more less tight-fitting, like a gaiter over that. That also dramatically improves the ability of the mask to filter particles and keep you safe.
Dr. Smith, do you have anything you would like to add?
No, I mean, I think Dr. Weber said that perfectly. The mask is the single most important thing. So, in regard to this question, this is not the time to let up on wearing a mask.
Particularly in a closed indoor setting. And even prior to getting the vaccines rolled out across our communities, we saw the implementation of good mask use in the hospital setting flatten the curve for spread of COVID within the hospitals. It's a high-risk setting. We are seeing patients that by nature of their care are not wearing a mask. They can't wear it maybe because of what they're dealing with. And we saw the use of masks, and we added some eye protection in higher risk settings, reduced the spread and flattened it, nearly eliminated it actually in the hospital setting. So we know it works, and vaccines add that the additional level that should help us as we go into the next few months.
Yeah, I'm sorry. And just one other thing to point out, that we call them variants, but it's not the type of variation that lets them permeate masks. So that's really important to remember.
I'd also like to add, as long as we mentioned variants, they may be more infectious and some of them may cause more severe disease. But again, they're the same size, they don't penetrate masks. And I should also point out that the basic nature of the virus doesn't change. So the hand hygiene agents we use, soap and water removes them, alcohol will kill them, and the surface disinfectants we use work just as well on all the variants. So those are not features that change with the variants.
Yes, someone often says the variants do not mutate against the mask still works. So we have some of our registered guests who submitted questions beforehand. I wanted to just at least address one of them because it goes to a question that came up during our talk. We talk a lot about fully vaccinated, but Dr. Weber, can you explain more about what it means to be fully vaccinated? Is this a gradient? So do you get increasingly more vaccinated each day or more protected each day post your vaccine? And specifically, if you get the vaccine, you were exposed to a case prior to getting your vaccine, how likely are you to get infected?
So a whole series of very good questions. First, let me say it takes time to develop immunity, and it also depends whether it's a 1 or 2 dose vaccine. So normally it takes somewhere between 2 and 4 weeks after a vaccine to develop immunity. In both the Pfizer, Moderna, and the Johnson & Johnson single dose vaccine, you get little protection within the first 2 weeks. The protection increases rapidly then, and for the 2-dose vaccines, you have about 50% protection by the time you're ready for your second dose. And then after your second dose, it takes about another 2 weeks to be fully vaccinated. And so CDC says fully vaccinated means 2 weeks after the last dose of vaccine. So for Moderna and Pfizer, that's the second dose. And for Johnson & Johnson, it's roughly 2 weeks after the first dose. And I should say, we have seen people with the Moderna and Pfizer vaccines develop COVID between dose 1 and dose 2, although it is a reduced risk. We certainly have seen those patients. These vaccines, because they take at least a couple of weeks to really begin developing immunity, cannot be used for post-exposure prophylaxis, meaning if you're exposed today and I give you a vaccine the same day you're exposed, since the incubation period for COVID is really 2 to 14 days, most commonly about 5 or 6 days. That's just too fast for these to get any protection against those viruses. If you happen to have a virus that has a very long time before you become ill, such as virus or hepatitis A, for instance, hepatitis B, you can use vaccines to prevent you from becoming ill. But with diseases that have this very short period of time between when you're exposed to becoming ill, vaccines are not now, nor will they ever be effective in preventing you from becoming ill if you take it on the day of exposure or even a couple of days before.
So to add to that, I'm sure we all agree that you should be masking through this process of vaccination. So the presence of a mask during that exposure should also reduce your risk, which we've all alluded to. So we have a nuanced question about educators that are getting vaccinated, but have an altered immune system. So they know that they can still get the vaccine and they are getting the vaccine. Are there other things they should be thinking about in terms of which vaccine to get, or how that impacts their level of safety in the classroom? Dr. Smith, do you want to start off with that? It's sort of a nuanced question about immunocompromised educators who are vaccinated. Do they need anything else?
Well, again, I think, for the immediate time being, until you have higher rates of vaccination among everyone in the community, including students, it just kind of comes back to the importance of the 3 Ws and these other mitigation strategies. So again, I think what our group and other groups have shown, that if you follow those 3 Ws, the likelihood of transmission from a student to a teacher is very, very low. And again, if you're immunocompromised, you should certainly be vaccinated. And I think I see another question in the chat: if it's safer for students safer for teachers to be in the classroom if they're vaccinated. It may be, but again, the safest thing is to make sure everyone at the school and the teachers and the students are following the three Ws. I may have misunderstood the question, but I think it's just really important to reinforce the other mitigation strategies.
I just want to spend a moment, just clarify something for the audience. The way infectious disease doctors and physicians think, we break an abnormal response and increased susceptibility to infection into two groups. One of those who have underlying diseases that somewhat impair or make it easier for a person to become infected. Things like diabetes, renal failure, liver failure would be examples. And all of those people were included in the vaccine trials. And in general, they responded very well to vaccines, and they worked quite well in those groups, despite having all of those, what we would call underlying diseases and comorbidities. There might have been a slight decrease in how well the vaccines work, but it wasn't statistically significant. On the other hand, we talk about truly immunocompromised people who really can't mount a normal body defense against infection. Here we're talking about cancer patients, chemotherapy, people who have an organ transplant like a heart or a lung, or on highly immune suppressive medicines for diseases like ulcerative colitis. So there are many more people with these underlying diseases. In those people, the vaccine seems to work quite well. It's only in the much smaller group of immunocompromised patients, and we don't actually know, they weren't in the trials, so we don't know how well the vaccine works in those people. It might work almost as well as people who are otherwise well. It might work substantially less, but obviously if you have one of those immunocompromising conditions, your best protection is to wear your mask and wear it properly.
Great. Dr. Smith, we have a practical question. We've talked a lot about the benefits of getting vaccinated. If you have symptoms post-vaccination, should you still seek out testing? And I have a follow-up after that. You are muted.
Sorry. I think it depends on what your symptoms are. So again, when you look at the clinical trials, the side effects that we talked about, fever is not uncommon after vaccination. So if in the day or two after vaccination you have fever as your only symptom, I don't think you need to be tested. If your arm hurts, if your arm's red, if your arm's swollen, I don't think you need to be tested. However, if you have symptoms of acute COVID within a day or two after receiving your vaccine, so cough, runny nose, shortness of breath, loss of taste or smell, those things should prompt testing. And I know when I got vaccinated here at Duke Health, we gave a little handout for here are the things that are probably going to be expected after vaccine. Those things I already mentioned, the sore arm and the fever. Here are some things that could indicate you actually have COVID, and you should get tested for that.
Thank you. So what about surveillance testing? We know that some schools or some other settings are performing surveillance testing. This may also be limited by the local school guidance or the state's guidance. As we see more people vaccinated in the school setting, should they participate in surveillance testing? This may be just an opinion. Both Dr. Smith and Dr. Weber, would you like to weigh in? Dr. Weber, do you want to start us off?
Sure, I'll go ahead and start that then. First, I just want to say, and I'm not quite sure about the last question, but I wanted to say another type of testing you can do is antibody testing. And I should say there is no indication for being tested before you get a vaccine to see if you have antibodies. Even if you've had COVID, you get an excellent boost with the vaccine. People who had COVID were included in the trials. And the recommendation is even if you've had COVID to receive the vaccine, don't come in while you're still in the infectious period, that you should be immunized. Similarly, we don't know what the protective level of antibodies is, and not all antibody tests actually pick up the antibodies from a vaccine, because as I mentioned earlier, you're making antibodies to the spike protein. So if the antibody test is picking up antibodies to other parts of the virus, you would test negative, even though you're immune. And even if you test positive to an antibody test, that doesn't mean you may be fully protected. So there's no point in getting an antibody test before or after a vaccine. Now, in regard to surveillance testing, the answer is almost certainly at some point when the people in the United States are highly immunized, we will decrease surveillance testing. But at the current time, because we're just really opening up vaccines now to groups 3 and 4, that is teachers and essential workers. And again, you have to wait 2 weeks after your last dose. Many of those have not completed all the vaccine. There are no changes and recommendations for the use of surveillance testing, which is not specifically recommended, but is an adjunctive measure that can be used. Surveillance testing allows you to detect cases early and do a case finding and detection. But surveillance testing by itself is not, and I'll say that again, it is not a mitigation strategy. The mitigation strategies, if you heard, are wearing a mask, physical distancing, hand hygiene, and surface disinfection. But there can be value in early detection and case finding of people, and that's where surveillance testing comes in. Thank you.
Thank you. It often depends on the goals of the test. Dr. Smith, would you like to add anything?
Nope, that's an excellent answer. Thank you, Dr. Weber.
Wonderful. So we're coming towards the end of our session here. There is a question that I think probably alludes to the daily updates we get about newer vaccines that are coming up. So someone asked, would there be any nasal or oral vaccine available to the public? But also, as we see newer vaccines, are there points you would like to make about how we approach the new information? Dr. Smith.
So yeah, so a couple of points. So the vaccines that are currently in phase 3 randomized clinical trials, so kind of the immediate pre-licensure studies are all injectable vaccines. I'm not aware of any nasal or oral vaccines, even in the pipeline. There may be a couple early on in development, but certainly nothing that's ready for prime time that I'm aware of. And the other thing I think is you may have seen media reports that came out today about early effectiveness data from the AstraZeneca vaccine here into the United States. And it looked fairly favorable. I've only seen the press releases. And one thing I've learned during the pandemic, I think this is what you were getting at, is that we should not make any rapid judgments based on something that comes out just in a press release or something that comes out in these kind of preprint scientific publications. Really need to wait for formal FDA review before we comment on any new vaccines and their suitability for public consumption.
Absolutely, thank you for that. So for both of you, we're coming to the end of our talk session here. Could you just share any take-home points for the people listening, specifically focusing on vaccines, on COVID-19 vaccines, of course? Dr. Weber?
Well, we haven't really talked about vaccine hesitancy. I do want to point out that tens of millions of people have now received vaccine. Dr. Smith nicely talked about all the multiple ways we're looking at safety, and despite millions and millions of doses, we don't have safety signals that suggest the vaccines have major risks. Clearly, the biggest risk by far is getting COVID, and you're yourself becoming quite ill, with more than 500,000 Americans who have died. I'll also point out to you that something like 30% of people who have COVID, even mild cases, will go on and have symptoms that last for weeks or months. So even if you are not dying, you can have substantial health consequences of COVID there. So really, people do need to receive vaccines. The best place to get data on vaccines, besides the ABC Collaborative website, are on your state public health websites and the Centers for Disease Control websites. And I certainly encourage people to receive vaccines. As you've heard, 100,000 people in the trials. Vaccines do have the side effects, but severe side effects, incredibly rare, and a serious disease that we are preventing.
Dr. Smith, any last words?
No, I think Dr. Weber kind of said everything I was going to say. These vaccines are effective and they're safe. There's no reason not to be vaccinated. And just remember, though, for when it comes to coming back to school, there's ample data that show even before we had vaccines, schools can reopen safely. So when you take those data that it's safe to be back in school, and you add a product that is safe and effective, it really is a win-win for everybody. And thanks everyone for tuning in tonight.
Yes, thank you so much for your time. We have this recorded and we'll have it on our website. We'll also have access to other resources. Just remember your local public health department, the CDC, and certainly your school districts should have access to ways you can easily get vaccinated at this point as an educator. If there are any additional questions, please shoot us an email. Thank you all for your time. We will be wrapping up now.